Hello, my name's John Paul Leach. I'm a Professor of Clinical Neurology here in Glasgow in Scotland, and it's a pleasure for me to record this short lecture talking about epilepsy and its treatment. So I'm just going to share the screen and do that here. Hi, my name is John Paul Leach. I'm a consultant neurologist here in Glasgow, Glasgow University, and I'm delighted to speak to you today about epilepsy treatment hitting the brick wall. This is a nighttime view of Glasgow, and a wee bit of background. First of all, you'll have heard of Scotland. It's the northernmost part of the United Kingdom, this bit in red here. Some would argue it's the most beautiful. I'm not going to say that. The accent, of course, is difficult, and for that, I apologise today. But Scotland's around about 6 million inhabitants, and it's 10% of the population of the UK, but around about 20% of the landmass of the UK. So it's a bit less crowded than much of the rest of the UK. And it's famous for many things. It's famous for its men in kilts, it's famous for its whisky, and it's famous for its golf. And this is the oldest golf course in the world, St Andrews. I want to talk to you today about epilepsy, and I want to talk about some of the myths around epilepsy and some of the things that we have to realise about epilepsy when we're helping to deal with patients. It's a very common disease. About 1 in 200 of any given population will be on medication with epilepsy. And we know that around about 5 to 10% of the population will have a seizure at any point in their lives. So it's not just a disease of childhood. One of the times of highest incidence is before the age of 5, but actually by the time you get to the age of 50, 55, your incidence begins to climb again. So it's a very U-shaped curve of incidence of epilepsy, common in both children and older adults. This, of course, is a disease that requires treatment. It's a disease that consists of a tendency towards spontaneous seizures. And seizures are just, as you know, electrical discharges in the brain caused by an imbalance of excitation and inhibition. And this is something that lends itself very well to manipulation with drug treatment. The experience of epilepsy, the fact is that in most cases, epilepsy will respond well to treatment. So this is the usual outcome. We know that consultants obviously have to make do with patients who maybe often don't respond. So we have a mixed view, but on the whole, think that the outcome is usually good. The problem is that for doctors on call or people who don't have experience of epilepsy, the only patients they see are patients with very difficult to control epilepsy. So I would argue that non-specialists will often have a very distorted view of what epilepsy involves and its responsiveness to treatment. This is what we know. This is a very famous study from around about 2000s, came from the Glasgow group here, Professor Brodie and Professor Kwan, and they looked at the outcome of epilepsy in around about 500 patients. The message here is that for around 2/3 of patients, the patients will become seizure-free on the first or second drug that we try. Now that leaves around 1 in 3 patients who will not become seizure-free, and they're the ones that I want to concentrate on today and talk about the kind of things that we can do to help improve their quality of life. And I want to talk about historically how things have changed. Now, up until the 1980s, we had very few anti-seizure medications. And what we've seen since a lot of investment in the 1990s is many, many more drugs coming on stream for treatment of epilepsy. And we thought that come 2010, that the number of drugs would dry up and would stop becoming an increasing. But this pipeline does appear to be carrying on. And there's no doubt that there are plenty more medications that are currently being investigated as useful for epilepsy. This does lead to a wee bit of a disappointment though, because we know that over the last 20 years or so, even with introduction of most of the new drugs, the number of people becoming seizure-free has remained virtually the same. Now, I would say that yes, that's true. The number of people who are seizure-free is virtually the same, but actually many of these patients are on treatment that's much better tolerated and causes far fewer side effects and has far less impact on their quality of life. One of the issues that we see in clinics is that all the people that we treat who do well will then discharge back to the care out of hospital clinics, and they'll be seen by their general practitioner or some other medical services on a very infrequent basis. But the patients who don't respond, that 1/3 who don't respond to the initial few sets of medication, will keep on coming back. And what can we do for these people? what can we do to try and improve their quality of life and try and improve their epilepsy? Well, there's absolutely no doubt that seizure freedom is going to be important here. Getting people seizure-free, removing the social effects of epilepsy, removing the medical risks of injury and coming to harm from seizures, and of course, improving independence. What's important, though, is not just to lose sight of the fact that we can't just flood people with high-dose medications. We need to make sure that we work hard to try and reduce the burden of side effects. And there are certain things that we can do in clinics, continuing to review the diagnosis, make sure that it is epilepsy, make sure we get the type of epilepsy right, making sure that the patient's taking the medication that we're prescribing, and of course making sure that other things are not affecting them badly. 1 in 3 patients with epilepsy will have anxiety or depression, so reducing comorbidities is important. Making sure that there are no other drugs or excess alcohol in the background that might affect seizure control, and using imaging to make sure there's no other new lesions that have developed are important here. So if we know that refractory epilepsy is there and we know that we've taken all these steps to try and improve quality, are there other things that we can do? Well, actually, we want to try and reduce seizures as much as we can, and doing so will mean adding in some medications. Now, what we have to realise is we have to be realistic to patients and say that we know that the more drugs that you add, you will have some more people who will become seizure-free, but it's less of an impact with each one. And we know that when you move on to the 4th, 5th, 6th, 7th choice of drug, then the number of patients who will develop new seizure freedom is pretty small. Not insignificant, not trivial, but it's relatively small and not the expected outcome. This is the graph that we show here. The more drugs that we add in, the more the patients failed in medication in the past, the less chance there is of becoming seizure-free with the next additional medication. So seizure freedom we see here, but one of the other measures that we often use in epilepsy studies is a greater than 50% reduction in seizure frequency. So somebody's gone from 4 seizures a month down to, say, at least 2 seizures a month. And these are recognised measures in our epilepsy studies. What about real life? If we move away from epilepsy studies, what about real life? Well, we know that if you add in some of the newer anti-seizure medications, even if people have missed out and full control with their previous medications, that actually the newer drugs will give a variable degree of control, around about 1 in 4 or around about 1 in 10. And these are patients who will be completely seizure-free with the new medication added in. So we need to keep looking for the next anti-seizure medicine for our patients. We need to keep on developing anti-seizure medications. But actually, I would argue that in addition to this, we need to be using the anti-seizure medicines that we've got a bit more effectively, managing to use them in combination, becoming experienced in the use and being able to mix them so that we get some proper synergism between the medications. There are some cases, of course, where anti-seizure medicines don't work, and we have to think on other methods of controlling epilepsy. And I want to just talk a wee bit about epilepsy surgery. This is something that we thought was going to open a new vista of opportunities for our patients in the 80s and 90s, but actually the number of patients with epilepsy who are open to epilepsy surgery, a well-recognised focus of epileptic activity that can be removed without causing neurological deficit. When we can do that, and it's a small number of patients, but when we can do that, we can actually get a good number of these patients seizure-free in the long run. And that's useful because we get them seizure-free. If this is the slide here looking at temporal epilepsy, which for reasons nobody really understands, seems to be the seat of much of refractory epilepsy. But you can see that around about 4 in 10, up to 8 in 10 in some studies will be seizure-free after a successful temporal lobe resection. Once you move away from the temporal lobe, the epilepsy surgery becomes a bit less successful, but still 1 in 4 to 1 in 2 will become seizure-free with a successful seizure workup and a successful operation. Just touch on stimulated device. The success of the stimulated device industry in the last 20 years has been, if anything, slightly disappointing. You can stimulate the vagus nerve, you can insert deep brain stimulation into the thalamus, and that can bring about seizure freedom in some patients. For vagal nerve stimulation, around about 8%, but not many for thalamic stimulation. These will be safe for patients with a very severe epilepsy. Of course, not just an operation that's needed, not just a continual revision of operation with replacement of batteries every few years, but actually the expense of these devices is a significant issue, and we have to remember that. There is some research going on looking at responsive neurostimulators, where patients will have a seizure and the device will kick in as it would do with, say, a pacemaker or a defibrillator. We know that seizure freedom is the ultimate goal. We know that we have to recognise that it is attainable at an early stage for most of our patients with epilepsy, and for a few it's attainable late, even after failure. And I would argue that although it's easy to be sometimes nihilistic about treatment and decide that patients are not going to be seizure free, it's not worth the effort of continuing to try, I would say that it's always worth trying. Thanks very much. I hope you enjoy the rest of the conference, and greetings here from Glasgow. So nice to speak to you. Just a pleasure I can't be there in person. Thank you very much.